All right. Welcome, everyone. I am going to get started. My name is Lauren Tobias, and I'm going to be moderating today's Yale Sleep Seminar. I have a few quick announcements before I introduce our speaker this afternoon. In order to receive CME credit for attendance, please see the chat room for instructions. You can text the unique ID for this conference anytime until 3:15 p.m. I do encourage you to make use of the chat room throughout the hour as questions arise, and we'll have some time at the end for our folks to unmute themselves and ask questions aloud. Finally, please feel free to share the announcements for this weekly lecture series to anyone else who may be interested, and you can contact our admin, Debbie Lovejoy, to be added to our email list. So now it is my great pleasure to introduce our speaker for this afternoon, Dr. Rafael Sepulveda-Acosta. Dr. Sepulveda-Acosta received his medical degree from Mount Vernon Hospital in Valhalla, followed by an internal medicine residency at the Universidad Central del Caribe in Puerto Rico, and finally a sleep medicine fellowship at the University of Tennessee Health Science Center. He also was obesity medicine board certified in 2020, after which he founded the practice Sleep Fit Medical in Sonoma, California, where he's now medical director. Given his unique expertise and experience at the intersection of sleep medicine and obesity medicine, Dr. Sepulveda-Acosta has been highly sought out as a speaker on this topic, particularly since the FDA approval of tirzepatide for the indication of sleep apnea treatment earlier this year. He was an invited speaker on the most recent episode of the wonderful AASM Sleep podcast, Talking Sleep, and a panelist in the AASM live webcast that was done on this topic in February that I believe several of us here were listening to. He's also written on this topic for Sleep Review magazine, the ASM Montage, and Sleep World magazine. He's frequently quoted in the popular press on this topic. And I know that our audience today, along with much of the sleep medicine world, has a lot of questions about how to incorporate the use of weight loss medications into our clinical practice. So we're all eager to hear what Dr. Sepulveda can share with us this afternoon. So with that, please join me in giving him a warm welcome for his talk, which is entitled Transforming Sleep Care, Integrating Novel and Conventional Anti-Obesity Pharmacotherapy with Weight Management in Sleep Medicine. And I'll turn it over to you.
Thank you so much for the welcome. So let's get started. So I have no conflict of interest with or any disclosures. So the learning objectives is to identify the role of anti-obesity pharmacotherapy and the integration as part of the management of sleep disorders. Also, we want to enhance patient care by implementing proper dosing, treatment response monitoring, and navigating insurance processes. We also want to make sure that we incorporate nutrition, physical activity, and behavioral modification to improve pharmacotherapy outcomes and sleep health and long-term weight management.
Quick interruption. We can't see your slides.
Oh, let's see. So is it a black screen?
We're just seeing you as the speaker. We're not
Oh.
seeing your slide sharing.
Let me see. See. So let's do the sharing of the slides again. Can you see it now?
We've got it. Thank you. We see the whole, we see like the whole deck on the side. I don't know if you want to put it in. There you go. Perfect. Thank you.
All right. Sorry about that. All right, so let's first talk about the progression of the anti-obesity pharmacotherapy with the FDA approval timeline. So initially in the 1950s and 1960s, phentermine and diethylpropion, which are centrally acting sympathomimetics, were very popular in terms of weight loss. But they faced some concerns with cardiovascular risk and some abuse potential. Now, in the 70s and 80s, fenfluramine and dextromethorphan came up. And they were serotonin releasing agents. They were very popular at that time. But then there were some concerns with primary pulmonary hypertension with its use. Now, in the early 90s, fen-phen, as they used to call it, which is a combination of fenfluramine and phentermine, were widespread, perceived to have a very great efficacy for weight loss. But later, there were some concerns with valvulopathies, and it was withdrawn from the market in 1997. Now, in 1999, orlistat, which is a lipase inhibitor, was approved for weight loss. But then there were some problems with tolerance, due to gastrointestinal and malabsorption effects of the medication. In 2012, then phentermine topiramate combination, branded as Kisimia, was approved for adult chronic weight management. Now, in December of 2014, liraglutide, branded as Saxenda, was approved for adult obesity. Now, semaglutide was approved in June of 2021 for adults with obesity or overweight with at least one weight-related condition. And in 2023, tirzepatide, branded as Zepbound, was approved for chronic weight management. Now, last year in December 20th, in 2024, tirzepatide became the first pharmacotherapy approved by the FDA for the treatment of moderate to severe obstructive sleep apnea in adults with obesity. So how do we get to the first indication of anti-obesity pharmacotherapy for obstructive sleep apnea? So initially, the first anti-obesity medication that was studied was phentermine topiramate. And there was a very small study with 45 participants where they did a 28-week study. Patients would have, or participants will have a high BMI between 30 and 40 and moderate to severe RSA. Now, the results were that total body weight loss of 6% was achieved, and an AHI reduction of 15 events per hour. 24% of the patients reach a baseline AHI that will be considered resolution. So that was considered a little bit ineffective, even though there was improved on oxygen saturation and reduced blood pressure as a result. Now, the treatment was well tolerated with minimal side effects, and it just suggested the potential option of anti-obesity medications for treatment of OSA. Now, years later, liraglutide was studied in non-diabetic participants. So they did a 32-week trial using 3 milligrams of liraglutide with initial escalation from 0.6 milligrams to up to 3 milligrams. It was studied in moderate to severe obstructive sleep apnea. All patients went a caloric deficit of 500 kilocalories from their total energy expenditure. And they all were involved in physical activity at least more than 150 minutes a week. Now, the results of that study was that it resulted in a 4% of total body weight reduction and a modest reduction of the AHI of 6 events per hour from baseline. The main concern with that was that 50% of the severe patients remain at their baseline severity, and only 5% had resolution to a normal AHI. Now, this result suggested that with greater weight loss, it might lead to better improvement of the AHI. And that liraglutide with diet and exercise could be effective for weight management and treatment of obstructive sleep apnea. Now, there was another study in patients with diabetes type 2 on severe obstructive sleep apnea. Again, a pretty small sample of participants. It also resulted in a decline of AHI by 6 events per hour and a 2-point drop in their BMI after 3 months. So again, this suggested that liraglutide in combination with CPAP can potentially be improving AHI and weight-related outcomes, including decrease in systolic blood pressure. In terms of semaglutide, which is kind of like the first of the new generations of anti-obesity medications, it hasn't been formally studied specifically in a population with obesity and obstructive sleep apnea, and with the reduction of apnea-hypopnea index after weight loss. Now, the main study that we consider for the approval of incretins for obstructive sleep apnea was the SURMOUNT-OSA trial, which I assume a lot of the fellows are pretty familiar with. So basically, what was impressive about the SURMOUNT-OSA in the phase 1 is that the AHI was decreasing 51% in comparison to placebo, and 70% of the participants had more than 50% of reduction in their AHI from their baseline. Also, there was a significant percentage of total body weight at the 52-week mark, and even more at 72 weeks. Now, in patients that underwent CPAP treatment in that phase of the study, they noticed even a higher percentage in the AHI decrease and a higher percentage of reduction of AHI. So this caught the attention for the treatment of obstructive sleep apnea. So in this case, these improvements were sustained effects at 88 weeks. And then it noticed that fat loss in critical areas like tongue, pharyngeal airway, and abdomen can predict a better AHI improvement. So the tirzepatide was exceeded the expected AHI improvement in comparison to other weight loss anti-obesity medications. Now, how does tirzepatide works? So tirzepatide binds to a GLP-1 receptor, a glucagon-like peptide 1, and a gastric inhibitory polypeptide receptor. So it has what we call dual action. So it basically activates the protein kinase A pathway. This stimulates glucose metabolism and increase the release of insulin in the bloodstream. Also, through that protein kinase A pathway, it stimulates insulin gene transcriptions with increased insulin synthesis. Now, in a patient with type 2 diabetes or with insulin resistant, it basically fills out those receptors and does the insulin synthesis and increase in insulin in the bloodstream. But in a patient that does not have insulin resistance or type 2 diabetes, it basically overstimulates the receptors in the hypothalamus, resulting in a decreased appetite, decrease of food intake, and resulting weight loss. Now, what's important about the weight loss of the tongue and the soft tissue? So this is a study that even though they didn't use anti-obesity medications, that it shows that weight loss significantly helps the improvement of the percentage of AHI. So this study was done in 67 participants with moderate to severe OSA and obesity. They underwent bariatric surgery in comparison to just only lifestyle modification in the control group. And they did polysomnography at the beginning of the study and 6 months after, accompanied by an MRI, pre and post bariatric intervention. And they evaluated the percent of fat reduction in the tongue and the thorax and abdomen, and they compared the AHI percentage change. Now, the results show an average of 9.5 total body weight reduction according to baseline, and 30.7% improvement in the AHI. All patients that lost more than 2.5% of total body weight have more significant AHI reduction compared to no change if they did not have more than 2.5% of total body weight. So this suggests a very strong positive correlation between tongue fat change and with weight loss to achieve an AHI reduction. Analysis also suggested that tongue fat percentage reduction was a primary upper airway mediator between weight loss percent and AHI reduction. Now, this is some MRIs, actual MRIs of the tongue. You can see that, and they compared the pre-bariatric surgery weight and AHI and the post-bariatric surgery after 6 months. So you can see that the yellow is basically fat tissue in comparison to muscle. You can see a significant decrease. And if you look correlation between BMI and AHI, there's a significant difference in that outcome. Now, they did the same thing of the adiposity around the chest and abdomen. And you can see here that, when pre and post also shows a very significant decrease in subcutaneous and visceral fat. Now, what are the indications for tirzepatide and obstructive sleep apnea? So basically, it's done for moderate to severe obstructive sleep apnea. This was studied at a 4% AHI hypopnea classification. And it's only for patients that have a BMI of 30 or above. And it also should be qualified a patient in conjunction with nutrition, physical activity, and behavioral modification. Now, what to do for insurance authorizations to get approved for tirzepatide in obstructive sleep apnea? So first of all, in clinical assessment, we should document signs and symptoms, make sure that we document sleep testing results that goes with the according criteria, that the BMI is within the 30 or more, and that the patient agrees with starting therapy with tirzepatide. In terms of ICD-10 codes, we can use the G47.33 as obstructive sleep apnea, combined with the E66.9 for obesity, and the C codes, which are the BMI codes, the C68.30 to 39, or 41 to 45. We also recommend to attach their sleep study to confirm their diagnosis, and attach a letter of medical necessity, basically mentioning that the patient meets FDA criteria for the treatment of tirzepatide in obstructive sleep apnea, and that the patient's criteria is been met in order to get approved. However, this still a very great topic, because some pharmacy benefit managers have different criteria. Now, how does the dosing schedule works? So basically, the lowest dose is 2.5. It's not considered a therapeutic dose. It's every dose is increased by 4 weeks. We also recommend as in obesity medicine to create or order some baseline lab tests, specifically CBC, lipid panel, thyroid, CMPs, and more specific labs if the patient has undergone bariatric surgery, just to make sure that there's not a vitamin deficiency or any kind of deficiency that we might need to correct, or that would contraindicate the use of tirzepatide. Now, every 4 weeks, we kind of increase the dose. The 5 milligram dose is considered maintenance for weight reduction only. But in order to be of treatment for obstructive sleep apnea, we should escalate the dose to 10 milligrams and 15 milligrams. So those are considered the maintenance dose, 10 milligrams and 15 milligrams for obstructive sleep apnea. Now, compounded tirzepatide. So that's a very controversial topic currently. Compounded medications were kind of approved mostly due to a drug shortage that happened in December of 2022. And then in October of 2024, this drug shortage was determined to be resolved according to the FDA. It was back reevaluated in December of 2024, and as of March 19 of this year, the FDA recommended cessation of distribution and dispensing of compounded tirzepatide. The problem with compounded medications in general was that until February 28 of this year, there's been reported more than 320 cases of adverse effects of compounded tirzepatide. Most of them are related to dosing errors and adverse events, mostly if patients self-administer incorrect doses or miscalculating our dosages. These common errors have happened because patients mistakenly have been drawn 5 to 20 times the intended dose, mainly because of converting dosage and different units depending on the formulation. The most common adverse effects reported are pancreatitis, gallstones, severe nausea and vomiting, and severe dehydration. So we also have to take into account that non-FDA approved products, compounded tirzepatide, varies in concentration, efficacy, packaging, and instructions. So this increased the risk for dose errors. In general, for patient or provider guidance, the main recommendations is to make sure that the patient has the appropriate size syringe, they understand how to measure the compound properly, and making sure that the patients do not prefer the FDA approved version of the medication. So what are contraindications for tirzepatide? So the main one, it's thyroid cancer risk. This is for patients that have personal or family history of medullary carcinoma of the thyroid, or multiple endocrine neoplasia syndrome type 2, or MEN2. Now, this recommendation, it's important to clarify that this was basically a recommendation given that in animal models, there was this finding. However, there wasn't any base for this contraindication in human trials. Now, severe gastroparesis or gastrointestinal disorders is not recommended because tirzepatide slows down your gastric emptying. Suicidal behavior, aspiration risk under anesthesia or deep sedation. Generally, the recommendations is based on the fact that delayed gastric emptying would increase the pulmonary aspiration risk under anesthesia. So the recommendations, if the patient is in the medication, is to stop at least a week prior to surgery, and maybe longer, depending if the patient is undergoing general anesthesia. And also very, very important to when post-surgical, the patient is able to tolerate oral intake, then they can restart the medication. But this varies still to this day with, the surgical and anesthesia team deciding in a case-to-case basis. Pregnancy or lactation is not recommended. If a patient is planning pregnancy, it should be discontinued at least 2 months before conception. And there's insufficient data in terms of lactation. Then pediatric use is not being established, any safety or efficacy. And then in terms of reproductive impact, there is a very important claim of decreasing effectiveness of oral contraceptive. So it should be in those patients changed to a non-oral or a barrier method, even 4 weeks after starting or increasing tirzepatide. Now, it's also important that those adjustments should be considered in medications that have narrow therapeutic window, like warfarin or digoxin. There's also a possibility of delay effect in rapid onset medications. And if the patient has adverse effects like diarrhea or vomiting, this might reduce the efficacy of the oral contraceptives as well. There's no data on hormone replacement therapy, but because of the gastric emptying delay, it might affect oral hormone replacement therapy and progesterone. All right, so what are the most common side effects and the uncommon side effects? So the main ones that, even though uncommon, is severe gastrointestinal reactions, acute kidney injuries, probably second most common of the kind of consider uncommon side effects. This mostly happens because of dehydration. So we should monitor renal function in a patient with high risk. Also, in terms of gallbladder disease, there's an increased risk of gallbladder disease, so we should evaluate if any symptoms arrive. Pancreatitis, we should discontinue if we suspect pancreatitis. And it may worsen diabetic retinopathy, so we should monitor patients with a history of this condition and discontinue accordingly. Now, in terms of the common side effects, I'm going to be talking about it across the rest of the talk, because these are mostly gastrointestinal symptoms that we can try to mitigate ahead of time by just doing some nutritional and behavioral modification along the way. All right, so I'm gonna start with some nutritional management pearls. All right. So main recommendations. So carbohydrate intake. So very important is that quality over quantity it's the most important. So having meals that have high fiber and low glycemic index, especially in the first 48 to 72 hours after injection or a dose increase as well. High glycemic foods lead to increase of GI side effects due to delayed gastric emptying. So carbohydrate sources that we can recommend patients to use is kiwi, for example, tart cherry juice, cherries and leafy greens that actually would enhance sleep quality. Now, in terms of protein intake, it's recommended to have the patient have a higher than normal protein intake just to preserve a lean muscle mass. There's been a lot of controversy with lean muscle mass loss under these medications. So this is a way that we can prevent that from happening. And then making sure that the patient has the ideal protein availability and including kind of tryptophan-rich food sources. So some protein sources that we should consider to improve sleep quality is whole grains, vegetables, fruits, nuts, legumes, dairy, and some lean meats. Now, in terms of fat intake, we should try to prioritize healthy fats over ultra-processed fats. And obviously considering portion control through the day instead of big quantities. Prioritizing omega-3 and omega-6 fatty acids because this supports the secretion of melatonin and serotonin, which is very helpful with sleep. And some fat sources to improve sleep quality, obviously fatty fish, flax seeds, almonds, walnuts, avocado, and olive oil. Now, in terms of water intake, this is a point that patients would probably want to discuss quite a bit. So it's recommended for women around 9 cups a day, for men around 13. To have 2 cups of water before meals, extremely important. Most patients under the use of tirzepatide would complain of constipation, so this water would improve with that. And also water intake would prevent the chance of dehydration causing acute kidney injury. A lot of times you see this in patients that have reduced hunger, so their thirst is not significant. Now, chrononutrition is another part that we're very emphatic about in the obesity medicine side. So front-loading calories to enhance weight loss and tolerance of tirzepatide, meaning that we want to have probably a bigger meal in the morning and then kind of multiple smaller meals if possible. Because earlier meals tend to reduce ghrelin and hunger level through the day. And as I mentioned, multiple small meals would avoid GI adverse effects with the use of tirzepatide. Now, physical activity pearls. So in terms of aerobic activity, engaging in longer sessions of aerobic activity improves sleep quality. So it's recommended to have at least more than 150 minutes of moderate aerobic activity per week and more than 75 to 150 minutes of vigorous aerobic activity. And in this case, intensity matters. So we want to reach a moderate to vigorous activity because in comparison to light exercise, because it will enhance total sleep time, sleep efficiency, percentage of REM sleep, and it will reduce even sleep anxiety. Optimal timing for aerobic activity is considered, early morning or early afternoon. This helps with lowering body temperature before bedtime, and this would support also melatonin secretion at bedtime. Avoid evening workouts. This would reduce melatonin levels and might even impact negatively sleep efficiency and sleep quality. And consistency is key. So regular long-term aerobic exercise is proving lasting benefits to sleep health overall. Now, in terms of strengthening and resistance, physical activity and tirzepatides, we recommend patients to try to engage in strengthening or resistance activity at least twice a week to improve sleep quality. Muscle recruitment is extremely important, so this will help us prevent weight regain by increasing your resting metabolic rate and improving calorie consumption by those muscles. And obviously, individualization is extremely important. This, depends on the patient capability. Um, and it's very important to kind of create smart goals, meaning measurable goals that they can improve over time, and to get that physical activity as consistent as possible. So this is a very interesting study. It was done with 67 participants with moderate to severe obstructive sleep apnea and obesity. So they noticed that there wasn't, this was done over a year of having a group with doing yoga in comparison to a group that would not engage in physical and in resistant physical activity doing yoga. So there was not a significant weight reduction after a year. Or the AHI. However, the patients that had more than 40% reduction in AHI, the majority of them were in the yoga group in comparison to the control group. So this study suggested that lifestyle interventions, including yoga, in conjunction with dietary changes, can play a role in managing obstructive sleep apnea, even in individuals with overweight. So behavioral modification perils. So main thing in terms of behavior is to reduce complex carbohydrate intake and processed foods. Limiting ultra-processed foods, opt-in with healthier cooking methods like air frying or boiling, and eating dinner at least 2 hours before bedtime, and avoiding laying down after a meal is an extremely important behavioral measure, especially when there's a slowing of the gastric emptying. Optimize meal frequency and timing. So we prefer smaller meals per day with more frequency. In some cases, we should do kind of some time-restricted eating because it's been shown to improve sleep quality in some individuals. And again, encouraging adequate hydration. Hydration is going to be the key to be able to sustain and mitigate adverse effects from tirzepatide as well. All right, so how to individualize a plan in obstructive sleep apnea and obesity care. So in patients with mild OSA and overweight with BMI between 27 and 29.9, we always want to do weight management and lifestyle interventions, and obviously consider alternatives for obstructive sleep apnea treatment, oral appliances, even CPAP if the patient has comorbidities. And in this type of patients, we could consider, if there's comorbidities, to use the conventional anti-obesity pharmacotherapy that I mentioned at the beginning. So why manage patients that have mild OSA with weight loss? Is because in some studies, they suggest that patients with overweight and mild OSA can still benefit from weight loss of 10% or more, and get a significant reduction in obstructive sleep apnea symptoms and even AHI. Now, in patients with mild OSA, if they have a BMI higher than 30, so always weight management with lifestyle interventions, consider positive airway pressure, and if intolerant, other alternatives of obstructive sleep apnea. And again, if they have comorbidities, we can consider conventional anti-obesity pharmacotherapy. Well, moderate and severe OSA, where their BMI it's 27 to 29.9, so overweight. So at that point, again, lifestyle interventions and weight management, consider positive airway pressure, and you could consider also conventional anti-obesity therapy if there's other comorbidities. Now, in moderate to severe OSA with BMI higher than 30, again, lifestyle interventions and weight management, consider positive airway pressure with tirzepatide. If they're intolerant to PAP therapy, then consider all other alternative OSA treatments with tirzepatide. Now, when should obstructive sleep apnea be reevaluated after weight loss? So basically, this has been shown that if the patient has lost 10% of their total body weight in those increments, we should consider retesting again. This is because 10% total body weight loss had been associated with 26% of decrease in the AHI from what their baseline is. There's also improvement on the oxygen saturation in patients with moderate severe OSA. This is believed to be because of the reduction of that fat deposition around the neck and the airway, by the decrease in inflammation and fluid retention around the neck and thoracoabdominal wall, and the improvement of insulin sensitivity and cardiovascular function. It's very, very important, a key point that healthcare professionals should reinforce and counsel patients that weight loss does not guarantee a full remission for obstructive sleep apnea. Now, what actions should be taking if the obstructive sleep apnea is in remission? So basically discuss continuing tirzepatide as a maintenance dose, and also the financial and insurance considerations for it. In some cases, there's no coverage after the patient have lost their weight. You can also consider bridging with other anti-obesity pharmacotherapies for weight maintenance as well. Emphasizing close vigilance of weight management with ongoing lifestyle modifications. If a reduction in severity is achieved, you can also reevaluate obstructive sleep apnea and consider other treatment options that could be more consistent and more sustainable for the patient. But it's very, very important key point that we should engage in this discussion with the patient so they can understand what their options are. Now, why is it so important to consider continuation of therapy? So this is the SURMOUNT-4, which evaluated maintenance of weight reduction. So the main thing with this is that patients were randomized after 36 weeks of tirzepatide 10 or 15, and half of the participants were put in a control group where just received placebo in comparison to the patients that continued tirzepatide at their maintenance dose. And then this showed that a weight loss of 25.3% at 88 weeks. The continuation of tirzepatide resulted in 5.5% more of total body weight loss from week 36 to 88, in comparison to the weight regain in the control group of 14%. 57% of tirzepatide users lost at least 25% of their total body weight by week 88, in comparison to only 13% in the placebo group. And 89.5% of tirzepatide group maintained more than 80% of total body weight loss, in comparison to only 16.6% in the placebo group. So the key points of this study is that it's essential to continue tirzepatide in order to sustain weight loss and the metabolic benefits of it. There's always risk of weight regain after discontinuation of treatment. So long-term therapy is extremely important for effective obesity management. Now, what to discuss with patients in terms of pharmacotherapy and sleep. So main thing, and as we all know, there's an urgency to treat obstructive sleep apnea. It's a serious medical condition. If untreated, it can compromise daytime functioning and cause fatalities, and it's a progressive disorder. And tirzepatide is not necessarily an immediate solution. So weight loss takes time, and many patients should be pursuing a formal structural therapy with like CPAP or other alternatives while on tirzepatide. In some cases, weight loss alone may not fully resolve obstructive sleep apnea. Um, and the best outcomes with tirzepatide has been shown to be in combination therapy. Patient education remains crucial to a successful treatment, and regular follow-up sleep studies for reevaluation and tracking progress. It's important to do in all patients on tirzepatide. In terms of addressing patient expectations, we should set up very realistic goals, reinforce the importance of adherence to the therapy in order to get symptom relief, and discuss insurance coverage considerations and options with the patient. And that's all I have. Thank you so much.
Thank you so much. That was a wonderful overview and really appreciate the practical points at the end. I'm sure that there are going to be audience questions. I see one in the chat. So the first one is from one of our sleep fellows here, Ian Murphy, and he's asking, how do you counsel patients on the weight rebound risks of stopping tirzepatide? I think you just spoke a little bit briefly about that, but do you tell them that this is a lifelong medication up front?
Yeah, so I actually tell them, obesity is a ever-changing disorder, right? So we have what we call metabolic adaptation. So if we keep doing the same thing in terms of nutrition, physical activity, or even behaviors, sometimes our body just kind of gets conditioned to certain state. Discussing the use of medications and options is extremely important in the short run and in the long run. But most patients definitely would need to stay in the medication over a long term.
Great. Thank you. I want to encourage other people to please feel free to unmute and ask a question, or you can post one in the chat if you prefer, and I am happy to read them. I would love to hear a little bit more about how you handle the maybe tension between getting that repeat sleep study when a patient's lost 10% of their body weight and then continued approval for tirzepatide. I mean, just if it's possible to sort of give us a sense of how often you think, and I know some of this is a work in progress as we navigate new waters here,
Yeah.
but how often is reapproval necessary? How does changing insurance play into this? And will it potentially cause a problem if a patient loses weight and gets undiagnosed with sleep apnea? Does that impact their eligibility for these medications?
So from what I've seen, obviously this varies by state and insurance plans, but what I've seen is that most insurance have been using their baseline BMI as a starting point, right? I would say that most of the time, the main thing is reevaluation. At least it should happen, let's say, after the patient has been in 3 to 6 months of treatment, just to see how things are changing, right? But that 10% reevaluation is extremely important. Sometimes you have to document that the patient had lost 10% or more of their total body weight. And then after that, basically, the conversation comes down to what the results of that sleep study is. If the patient says, you know what, I'm consistent with my CPAP, I feel great, or I'm having struggle with using my CPAP, I would like to consider another type of therapy. But from what I've seen, and obviously this varies, but from what I've seen, most insurance would continue to cover as long as the patient is in a maintenance dose.
Okay.
Lauren, I can actually also comment on this as well. Hello.
Thanks.
Lovely to meet
Hi
you.
there.
My name's Brian.
Yeah, go on.
So my name's Brian. I'm a endocrinologist, obesity doctor, and sleep doctor, actually. So I'm on the other side of this. So when we see them in clinic, often when many of these patients, so insurance hates it when the weight gets too low. So often I have to write an appeal to insurance to say this is a chronic disease, and this patient needs to stay on therapy to maintain weight loss because obesity is a chronic disease. So appeals, unfortunately, are a big issue, and even with getting coverage for Zepbound nowadays, often the only way you'll get it through is through an appeal, right? So you'll put it in Zepbound. Patient has class 3 obesity, evidence of moderate to severe apnea. Insurance will knock it out, and you'll have to write an appeal, and then insurance will take it. So appeals are a big part of obesity medicine still. And so I absolutely agree, but writing letters is a big part of it.
Yeah. Yeah.
Thank you. That's really helpful. I guess, given your involvement in the ASM, Dr. Sepulveda, I'm wondering if you have any knowledge about initiatives that are ongoing to share just templates for some of this stuff. Because I think for a lot of people in clinical practice, there's just the practical hurdle of creating a workflow, creating the templates that are needed to get initial authorization and then appeals. Do you know if anything like that is going on at a society level?
So we have discussed that between different colleagues. It's just a lot of times it's very hard to create one size fits all type of template. So that's kind of what we've been discussing. What we have noticed is that usually, as long as we put in our letters of medical necessity and our appeals, the resource of, why are we thinking, hey, this patient has a chronic disease, and it's like you have a patient with diabetes, you don't stop their diabetes medications, they're still in remission. So it's not a curative type of disorder. So making sure that we put references in those letters and the specifics of the patient is extremely important.
Thank you. That's really helpful. I will read another question that comes again from Dr. Ian Murphy. So he says, what are your thoughts on the direct to consumer sales of tirzepatide by companies like Hims? Should we be telling patients to explore these options if insurance does not cover the drugs?
So the main thing with all the direct to consumers, and I think we talked about this a little bit in the Talking Sleep podcast. So the main thing is that a lot of this medication still within the compounding tirzepatide. So we don't really know its effectiveness in comparison to the FDA approved version of it. In general, I think the manufacturer has now what they call a vial program. Which basically what it removes is the auto-injector part of it, and it actually relieves some of the costs that can come with the auto-injectors. So that direct vial program is, from what I understand, it's the same FDA-approved formulation of tirzepatide, just at a lower cost because of the lower cost of manufacturing. So that's the one that obesity medicine physicians were recommending. But the direct to consumers, we still have our hesitation just because we don't know effectiveness and safety for patients.
Great. Thank you. We have a question from Dr. Françoise Roux, who is asking, are there any cases of NAION or non-arteritic anterior ischemic optic neuropathy with this medication? I don't know if you're aware of that. It looks in my 2-second Google search like it's been associated with semaglutide, and there are some articles about this.
Yeah, I really have no memory of seeing any kind of study that will fully evaluate that. I know that there's some rare cases that have been mentioned, but you know, it's the main thing is that we're still learning about this medication group, and you know, we just have to be vigilant about those. But I haven't seen it in my practice.
So I can comment on that as well, Lauren. If
Please.
two pieces. One, there was a mention of diabetic retinopathy, and that's really was from the SUSTAIN-6 trial that came up. And so in the SUSTAIN-6 trial, the thought behind the diabetic retinopathy was because there's a massive drop in blood sugar. So if you gave insulin to those patients, the retinopathy would have happened. So it wasn't clear that the GLP caused retinopathy. It was the drop in the blood sugar that might have caused that. The NAION cases, I think that there's been a few studies out there. I haven't seen it in clinical practice, but there are reports out there recently because of the ubiquitous use, and I don't think we have a good answer on that. And so from an eye disease standpoint, I don't think there's good evidence that GLP-1s cause retinopathy independent of the glucose drop. And the NAION, even the most recent study that I read on it was ho-hum, where they said we're not sure if there's an association. So I think that the data is still emerging on that. Certainly with old studies with Lira and other drugs, we haven't seen it. So I think it's exquisitely rare.
Yeah, it's pretty early to kind of attribute it to it.
Great, thank you. Another question, we have a question from Dr. Joyce Leonati in Arizona. And so she's asking, are there any studies on triple G agonists in the pipeline for OSA? The neuro trial, she's a neurologist by training, Evoke and Evoke Plus show cognitive benefits in addition to greater weight loss outcomes than the single GLP-1s.
Yeah, so I
aware.
think that stays that's still in phase 2 trial. So they are just evaluating for it and mostly in the weight management portion. I think once we get clear answers on the effects on weight management, then probably, you know, there's right now around 12 different agents that's still in different phases of trials for weight management. But I think once it gets approved for weight management, any of these agents would most likely be evaluated for obstructive sleep apnea, given, you know, what we know so far.
Great, thank you. We also have a question from Dr. Ian Weir in Norwalk. He says, since the HSAT may underestimate sleep apnea, have you had any success in getting approval for PSGs, specifically for mild OSA on an HSAT if a patient would like to get Zepbound? So if they have mild OSA and their weight qualifies them, but the severity isn't sufficient to qualify.
Yeah, so actually that's a very interesting question. So a lot of the time, to me, it just varies depending on the events in the HSAT seem to be declining their oxygenation significantly or not, right? So a lot of times I just start patients with mild obstructive sleep apnea on treatment and reevaluate. You know, if I notice that they're still kind of gaining weight, then I just ask for a diagnostic portion and a split night test, basically, to consider reevaluating severity, especially if they're kind of continuing to gain weight. But at the beginning, it's once you have a diagnosis of mild OSA, I haven't seen insurance wanting to approve a full PSG unless there's a therapeutic portion of that test. So that's kind of my observation from my practice. And I don't think there's a clear guideline about that type of situation in specifics.
I'm interested that you're able to get even a split night approval if they already have mild on the home test.
Yeah. So I mean, a lot of times in my case, the cases that come to mind has been patients that have been struggling with CPAP to begin with, just being intolerant. and they have gained some amount of weight from their initial diagnosis. So
Okay.
that is the two inclusion criteria where it's
Mhm.
been approved in my practice.
Gotcha. That makes sense. Thank you. I think I'll take a final question here, which is I'm not sure who this is coming from. And I believe this was addressed in the ASM webinar as well. So I'm curious to know how you or your clinic follows these patients. Are you checking labs, weight, side effects, responses, losing fat mass versus, lean fat mass versus overall body mass for um, to
Mhm.
compare basically? Do you
Yeah.
partner with endocrine or obesity management specialists to help you monitor? And how do you follow them up after they've lost the
So
weight?
I'm kind of in a very weird or kind of special situation, right? Because we basically have kind of the obesity medicine part of our practice and the sleep medicine part of our practice. So as a weight management clinic, we basically do bioelectric impedance or what we call body composition tests when we initiate treatment and after 6 months of treatment. So a lot of the time that helps us guide if the patient is actually having a decrease in lean muscle mass and if their fat percentage is decreasing over time. A lot of the time it's a lot of collaboration with endocrinologists, even cardiologists, primary care physicians. And if we see that the patient is losing weight and the rate of the weight loss is not really adequate for what we would want, meaning is it either too fast or it's too slow, then at times we can incorporate a body composition test in the management. Now, in terms of follow-ups, when we're escalating those, I tend to see my patients 3 weeks after they started the dose. So let's say after 2.5, then I see them at 3 weeks, make sure that there's not adverse effects, and then we decide, hey, are we gonna escalate it up? Do we need to stay there for a little bit longer? Especially when they're going to the 10 to 15 ratio milligrams. That is where we have to kind of be a little bit more conscious of adverse effects. Sometimes that checking is basically, a short telemedicine visit, just, making sure that everything's still working fine and that they don't have any adverse effects or anything. Now, once they're in their maintenance dose, usually I see them every 2-3 months just to make sure that everything's still good. And then that we reevaluate with PSG or an home sleep apnea test, depending on how the patient is doing.
Interesting. And what's the interval for that as far as ordering the follow-up study?
So that depends in the 10%, right? So if they have lost the 10%, we kind of say, hey, do you want to continue to the 15%? And then we kind of like a negotiation between patient and practitioner, right? And depending also in what their initial BMI is. So a patient with a BMI of 45, then you might want to kind of do that retesting when they have lost that 15% or even more. So that is very patient dependent, let's say. And it's definitely a discussion to kind of establish with the patient.
Great. Thank you so much. I see there's also a link posted in the chat by Dr. Parvati Singh, which has a JAMA article detailing some of those ophthalmologic complications we mentioned briefly earlier. Dr. Sepulveda-Acosta, thank you for such a great talk and so much practical information here. I think we're going to need to have a follow-up to this, maybe with some kind of case-based examples once we all get our feet wet a little bit more in this arena. But take care,
Sounds
and
great.
everyone will see you next week.
Thank you so much.
Thank you.
Have a good one.
Thanks. Bye.
Bye.